You've heard a lot today about SVV's quite impressive solid cancer selectivity in TEM-A. You've also heard a lot about our upcoming trial that will utilize our proprietary 8-gene set for SVV, including TEM-A, to select patients who will be treated with checkpoint inhibitors alone versus checkpoint inhibitors with SVV. I just wanted to finish up showing you a couple of slides on our multiple IV program and our SVV-based ARM program. Next slide, please. So we have a full program on developing the ability to dose patients intravenously over an extended period of time. As you heard from Aman, our previous trials were all done as a monotherapy and as just a single intravenous dose. So one major change since our first trials is all the knowledge that have come out of the relatively new immuno-oncology field. For example, the synergy that may be created by an agonist agent like SVV and checkpoint inhibitors, as Aman discussed. However, it is also now known that the best results for patients being treated with an immunotherapy regimen is that they should be treated over a 3 to 6 month period of time. And that's because you want to allow for enough time to actually build up cancer-specific T cells and cause tumor regression. Unfortunately, as it is for most oncolytic viruses or any gene therapy agent for that matter, neutralizing antibodies actually will occur after even a single IV administration. And a lot of these agents can't actually even go into the first systemic administration because those humans have pre-existing immunities. So while humans don't have any neutralizing antibodies to SVV, allowing perhaps 2 IV doses over a 14-day period, repeat administration is not possible for that time point. So one approach that is promising that we could present today is combining SVV with a known cancer agent called cyclophosphamide, and that's a common cancer therapeutic that's used in a variety of different cancer indications. What you can see here is a syngeneic immune competent murine tumor model where we do an IV administration when the mice have tumors. And you can see that in mice, neutralizing antibodies only come up for about 4 days. So you can see here with that black bars. And those levels are actually between like 1 in 1,000 to 1 in 4,000 neutralizing antibody levels. That's far too high to have any SVV reach the tumor and infect those cells after an IV administration past that 4-day time point. However, we can nearly abolish neutralizing antibodies by simply adding the equivalent dose in mice the clinical dose of cyclophosphamide. So this level is indeed conducive, as you can see there in the red bars, to subsequent IV administration. So interesting, on the right-hand side, you could see the effect of putting the two of them together with cyclophosphamide plus SVV, you get nearly all eradications in the cancer. And that's very quite likely due to SVV continuing to circulate now, so there's no neutralizing antibodies preventing it. So the tumor makes the virus, it gets out in circulation, doesn't have any effect on normal tissue that you've heard about, and then it can reinfect the tumor. There may also be an immune response going on here that helps in terms of this aspect. Next slide, please. So earlier you saw Mihnea talk about how we use an SVV that expresses green fluorescent protein to examine tumor selectivity. The same methodology can be effectively utilized in certain therapeutic genes in SVV. So our ARM virus agent should produce very high levels of therapeutic protein, but only in the tumor, and they should enhance that patient's cancer therapy. Critically important is that many cancer therapeutics, though, have toxicity, for instance, some checkpoint inhibitors. However, just like SVV's cancer selectivity, the inserted therapeutic gene will only be expressed when SVV is replicating, that's only in the tumor. So in that case, the toxicity will also be limited because the gene is expressed only in the tumor. So enhanced efficacy and lower toxicity. And we do feel that this platform has unlimited potential. Next slide. So I just wanted to show you that a couple of these. So this is just an example of the few SVV constructs we're developing. We actually have 14 of these ARM constructs in development right now. And the last slide, please. So in closing, SVV is perhaps a second to none cell cancer selective oncolytic virus and cell cancer specific gene therapy vehicle through our own program. So our data not only supports SVV as an incredible drug for cell cancers, but also as a drug for a very important cancer target that you heard a lot about today, TIM8. SVV also has pretty impressive ability to synergize with checkpoint inhibitors as individual agents, and we predict even better when the checkpoint inhibitor is encoded within the genome as an armed agent. In our trial, we'll be utilizing a biomarker panel, which is highly accurate in predicting SVV infection and works well with even formalin-fixed paraffin and embedded slides that are available for most solid cancer patients. And unlike most oncolytic virus and gene therapy agents, SVV or armed SVVs can also be manufactured at very low cost. Last, we feel like we're getting much closer to enabling multiple intravenous administration over a 3 to 6 month period, which should result in better treatment of the patient's cancer and a better outcome, as well as the patient's well-being, because it's much easier to do intravenous administration than it is to do intraterminal. I'd really like to thank you for your time, and I'd be happy to take any questions. And as a reminder, this symposium is going to be on our website.